had a horrid OB that broke my water and inserted monitor and catheters without telling me. I did not get skin-to-skin time and could not breastfeed until hours before I was discharged. It was a horrible birth experience.
One nurse I had was extremely rude and callous towards me and was very rough while checking my cervix.
I didn't receive epidural like I asked.
I feel that they should have shown more interest in how I would have liked my labor to go. They didn't try to comfort me in any way with my idea of labor and what I wanted to do. When I did ask them if I could do certain things to help with the pain, like walking around or getting in the shower, they told me no, but wouldn't give me a clear explanation of why.
When I was talking to my anesthesiologist, he was very rude. He basically told me I couldn't have an epidural because I was too fat.
The perinatal MD who read my ultrasound kept telling me I had a giant baby that might not come out vaginally, which was anxiety-producing, even though I knew that ultrasounds are not reliable. And indeed, he was normal-sized.
The worst part of our childbirth experience was the racist comments that they would make to my husband.
We're a queer family, and my partner is transgender. Even though we saw staff reading our birth plan that stated I was mom and my partner was dad, they still referred to my husband as she.
My name is Chris Alonso. I'm a midwife and I work to improve women's access to safe and respectful care, and I'm a second-year DRPH student at the Harvard School of Public Health. Today we're going to be talking about disrespect and abuse in childbirth. I'm here with Jean DeClercq, Professor of Public Health at the Boston University School of Public Health. So Jean, could you start by telling me a little bit about yourself and your role in the research?
Sure. I'm part of a team that has been working for years to do studies called Listening to Mothers. In those studies, one of the things we've done is, starting in the survey we did in 2011, asking women about their experiences with disrespect and abuse in birth. And our findings were pretty startling for us, and that's part of what we'll be discussing today, I hope.
So tell us more. What did it look like?
First, I think we need to understand that disrespect and abuse has different meanings in different contexts.
Okay.
And so I think people's normal association of this is with abuse, physical abuse, verbal abuse. And it certainly is that, but it also entails discrimination that might be much more subtle in this process. Oftentimes it involves women saying things like, nobody listened to me. I kept telling them I wanted this and no one would pay attention to me. It may also involve health systems issues. Certainly I know we'll talk later about the international context, but structural issues about the way facilities are developed that allow women to have, for example, privacy during a visit. All of these things can contribute to an atmosphere in which women feel uncomfortable, that their values are not being respected and that they're not being treated with the dignity that they absolutely deserve.
And what have you found in your research? Have you found that it varies by region? Does it vary by ethnicity? Does it vary by type of insurance?
Keep going. It's yes to all of that.
Okay.
One of the things we've done, so we did it in the 2011-12 survey, and we found nationally rates of about 14% overall. We did a more recent study in 2016, but that was just in California, where we found rates that were closer to around 9%, 8 to 9% of women would say there was a problem. And I think we actually have a slide that illustrates that next point. And what we did was we asked women, did you ever feel like you were being treated unfairly because of your race, ethnicity, your insurance status, the language you spoke? And one of the things that folks will be able to see on these slides is very distinct differences. Now, I should note, in the California case, the overall rates of women reporting this were much lower than we found in the earlier national survey, which could either mean there was an actual positive change, or it could be a matter that we were dealing with a subset of the population, only the California one. But as you can see in the slide, issues like the quote that you see there, the worst part of our childbirth experience was the racial comments that they would make to my husband. And so these are very powerful, and they're not without consequences, right? Because I was a childbirth educator for a number of years, and one of the things we always told people was that this is their experience and that the need is to engage with the experience. And if one feels like they're being oppressed at any one point, they're less likely to be able to relax, to have the contractions as strongly as they can be, and interact with the people around them in a very supportive way.
I wanted to ask you about that. Does this impact childbirth? Are we seeing, do we need more interventions if there's disrespect? How does it play out?
That's a very contextual question, right? I think one could argue we need less interventions. Depends what you mean by interventions, right? If we're talking medical interventions, oftentimes the conflict we see that women describe is based on a desire not to have particular interventions. Sometimes it happens the other way, but oftentimes it's in the context of, I didn't want to have an episiotomy and they gave me an episiotomy. One of the things we found was upwards of 70% of women who had an episiotomy, when we asked them, did you have a choice in the matter, said no, they didn't have a choice. Those findings also vary for women who were on Medicaid. That was up to 89% saying they had no choice about the matter.
Jean, can you explain what an episiotomy is?
I could, but I think a midwife could explain it much more effectively.
I've never done one. An episiotomy is when a woman's perineum is cut by a pair of scissors. It usually happens right before the head comes out. And the idea behind it was that the cut was done to prevent tearing, which is a bit like tearing down a house so that a hurricane doesn't push it over. Nowadays, we know, thanks to many years of research, that episiotomies only increase the pain of the perineum, of the muscles between the vagina and the anus during in the postpartum period, and it doesn't actually improve the outcomes of the baby. Babies don't come out faster, they don't come out breathing better, and in some circles it's actually been called genital mutilation because it can be incredibly painful, and the scar tissue and the long-term effects of it can be very painful.
Yeah, in our studies of postpartum pain, women who had an episiotomy had the highest reports of postpartum pain, almost similar to women who had a cesarean reporting long-term pain from their cesarean scar. There's very few cases where you really have to do one anymore. The rates now are generally down in the area around 5 or 6% on official hospital discharge reporting. Our surveys generally find slightly higher rates than that mothers report, which is kind of an interesting perspective as well. But at a minimum, one would hope that mothers would be engaged in that decision, that it wouldn't be asserted by a provider that you're going to have this and you really have no choice in the matter.
The worst thing about my care was my doctor threatening me to do a C-section if I couldn't figure out how to push correctly. He also pressured me to have an episiotomy.
The worst thing about the care my baby and I got while in the hospital for my recent birth was that the doctor did not give me a choice about receiving an episiotomy.
My episiotomy was the worst thing about my care. I am not sure why it was done, and I don't remember discussing it during my pregnancy. It has caused me physical problems since.
I would not have another episiotomy, as my recovery from that took away from the enjoyment of bonding with my baby. I don't believe I was given enough time to stretch down there before my episiotomy was performed. I wasn't offered advice or care for my episiotomy recovery. I had to find information online myself. I wasn't given any option or had a choice with my episiotomy either.
One of the things women report is when we ask them, and I think we have a slide on this a little later, that we ask them about whether or not they felt pressured to have a particular intervention. And one of the things that occurs in those cases is, and there you can see it, that about 14% of women said they felt pressured to have an induction, about 12% for an epidural. For women who hadn't had a cesarean before, about 9% said they felt pressure to have a cesarean. And for women who had had a cesarean before, almost a quarter of them said they felt pressured to have another cesarean. And so that's the more subtle version of it. Now, when we talk about disrespect and abuse in an international context, sometimes that does lead into more verbal abuse and actual physical abuse in some cases. And I think our guests will be able to speak to that eloquently. But in these cases, it's a more subtle sense of the institution is not supportive of me, that they have an agenda and I'm to correspond to that agenda regardless of what my own wishes may be. And that's where we see the conflict in the United States quite often.
Being pressured into starting Pitocin resulted in very strong contractions sooner than I was ready.
My medical doctor did an induction method on me, swept my membranes without my consent.
I didn't like that they pressured me to have a C-section when I clearly wanted a natural birth. I didn't like that they kept on telling me if I don't get a C-section, then my baby will die.
No one really believed I could achieve a VBAC and kept giving me all the reasons why it wouldn't work, even though they supported my choice.
A doctor in the NICU ordered the nurse to feed my baby formula without my consent, and it messed up my plans for exclusive breastfeeding.
The hospital I would be delivering at would not let me have a vaginal birth because I had a previous C-section.
I was frustrated that I had to be induced. They seemed to have a policy that they applied to everyone regarding not going past their due date no matter how their monitoring is going.
Jean, can you tell me how this became an issue in the U.S.? How did we turn this into a public health issue? A lot of times we hear, accounts of women having a complaint about their birth or talking about a personal experience. And I'm wondering how a personal narrative, which could seem like, well, not everyone gets what they want out of birth, or sometimes things go differently, how does that turn into a public health problem of this magnitude?
Short of going through the 100 years of cultural warping of childbirth, I think the way this actually manifests itself is once you actually start asking women about their experiences, which we didn't do. We had no systematic ways of collecting the experiences of mothers regarding their childbirth experiences until fairly recently. We could have done it, we never valued it enough. And so once we started doing that, and once you think to ask the question, suddenly you identify this whole realm that you didn't understand existed before. And so I was lucky enough to be part of a large team that was looking more explicitly at mistreatment with a much more elaborate series of questions around it. And you see what those questions are on the slide that's presented now. And I think the important number is the one at the bottom, that 17% of women, about 1 in 6 women reported that they had experienced some type of mistreatment. Again, it's not typically verbal or physical abuse so much as lack of attention, lack of care given to them. And in some cases it is scolding, as one of the responses notes. If you go to the next slide, one of the things you see is that this mistreatment varies widely by race and ethnicity, or whether or not one is from an indigenous population. And when you're talking about the likelihood of mistreatment being 2.5 times higher for some people than others, then you understand that the problem is deeper and more involved than we may want to admit. One of the other things that was interesting was we asked this question and broke it out by where people gave birth. And if you go to the next slide, one of the things you see in this is the folks who reported the highest level were people who had started to have a birth either at home or in a freestanding birth center that had to be transferred to the hospital, then hospitals, and not surprisingly, people who give birth out of a hospital are more likely to report fewer cases of this because, of course, the whole setting at home is in the mother's control and much more in the mother's control. Now, the point of this is not that everybody needs to have a home birth. The point is that we need to restructure systems so people feel empowered in those systems to be able to do that. I want to note one particular case, that issue of the transfer. We had repeated stories of people when they were transferred who would be verbally abused by the people at the hospital about why did you go ahead and do that? Why did you try to do that at home when you should have always come here to the hospital? And that's, when we talk about solutions, that's part of what people are trying to work towards to resolve those kinds of problems.
So Jean, tell us about listening to mothers. How did it come about? How did you do it?
Well, certainly didn't do it alone. It's been a collaboration, primarily 3 people throughout the process. Myself, Carol Sakala, Maureen Corey. The quick history of this is I was presenting at a meeting. I talked about how I wish there was a survey like this of mothers. This is back around year 2000. And Maureen was in the audience. Maureen Corey was in the audience. And she came up to me afterwards and we started talking because that had been her dream too. And unlike me, she has skills and she was able to actually raise the money to do it. And I just talk about it. And so since then this collaborative team has been able to do 4 of these surveys. And the premise behind it is what I mentioned briefly earlier, that you're not going to know what women's experiences are unless you actually talk to women. And more importantly, listen to women. And so the evolution of this has been, we've learned from each of the surveys and tried to refine them. Specifically, the cases of asking about disrespect and abuse were a function of some of the work that Carol and Maureen had done in focus groups and talking to women and listening to women in small groups. And they identified this problem, and we started asking those questions. And again, once you do, you open up this world of experiences that people hadn't been talking about. Again, I was a childbirth educator, and you heard it there, right? When you would have the post-childbirth classes session with people would pour out their stories about what had happened. But those weren't being collected in any systematic way. The premise of listening to mothers was that we wanted to try to collect them and broadcast them to as wide an audience as we possibly could.
Okay. And once you had the results of listening to mothers, what happened? Do you think that this has pushed the needle? Has it impacted policy or people talking about this? Did this help to make disrespect and abuse an issue in public health in the U.S.?
Probably. I don't want to overrate the power of any one study, but my colleagues on this have been doing a terrific job of getting the word out. This most recent survey, the one we're presenting results from here, in California, had the most elaborate sort of follow-up. We work with the California Healthcare Foundation, and they do an amazing job of taking the raw data, which is my interest, and translating it into stories. They produced videos and infographics to try to get these points across. Again, one of the things, I don't want this to be completely negative, because if you look at the data, one of the things that becomes clear is that we're not talking huge numbers. We're not talking 40 or 50% of women experiencing this. In our Listening to Mothers California survey, it's roughly around 6 or 7%.
Okay.
So that, the positive side, it means 94% of people are saying, I did not have a problem with this. And that needs to be understood. What's disturbing is the degree of variation we see by different subgroups. We have a slide here that looks at it by payer source. And what you see is for mothers on Medi-Cal, they're about 4 times more likely than mothers on private insurance to report that they felt they were being treated unfairly because of the payer source. And I think that quote captures it beautifully. With my first child, I had Medi-Cal, and with my third, I had private insurance, and quality of care and doctors' interest in patients was different. So it's sort of like a small mini experiment there in terms of her own experiences. But we saw that theme come up again and again and again. If you look at the next slide on this, where we talk about treatment by language, I think what's striking is that it's actually highest for those mothers who self-identified as being Asian or Pacific Islander. We discussed this for a long time amongst ourselves, trying to figure out reasons behind this and why it wasn't higher for Spanish-speaking mothers. In the national survey we had done, it was much higher for Spanish-speaking mothers than it was for English-speaking mothers. That wasn't the case in California, but that may reflect one of the ways that we can get to solutions around this. And that is, in California, about 43% of the births are to mothers of Hispanic heritage. And our assumption is various hospitals and other service providers have become more experienced at working with people from, in this case, a lot of them were literally from Mexico, and started to set up more culturally appropriate, more language appropriate services to deal with that. For mothers of Asian background, they were reporting they didn't get the same kinds of levels. Now, it's not a huge difference there, but it is notable that it's the exception to the rule, but that may be a reflection of the fact that California has geared up its services for mothers of Hispanic heritage.
However, these studies keep bringing up ethnic and racial disparities. We keep seeing these completely different outcomes of white women versus women of color. What's going on?
When you have a mostly all-white workforce serving people from different cultures, it's probably not a shock that there's some cultural divisions that are happening. And the phrase of the day is, of course, implicit bias training. And we may get into that more when we talk about solutions to this. But one of the ways you can try to deal with this is through diversifying that workforce. Now that's a longer term solution, but that's the real solution to this. And one of the ways to do it is to broaden the number of midwives that we have providing care in the United States. What we have right now is a situation that's the reverse of most countries in the world that have the predominant birth attendants being midwives and obstetricians stepping in to deal with higher risk cases. In the United States, we flip that, where the overwhelming proportion of births are attended by physicians. Around 12% of births in the United States are attended by midwives. And in those cases, that's an unnecessary expenditure of resources. If we relied more on midwives, who, well, at the moment are no more diverse than our obstetricians, but some of the movements that are going on right now are really aimed at trying to improve that balance. One of the differences is you can train midwives in 3 years. It takes 8 or 9 to get an obstetrician trained. So if we want to try to diversify the workforce, this would be the great first step to take.
Okay.
And in that way, at least cut down on the potential for cultural barriers. That's not all that's involved in it, but that would be one big step.
So now I'm here with Anna Langer, Professor of Global Health and Population at the Harvard School of Public Health. Anna, welcome. Tell us a little bit about yourself.
Thank you, Chris. Yes, as you pointed out, I'm a professor of the practice in the Global Health and Population Department. I am a physician by training, originally from Argentina, lived for many, many years in Mexico, and I have been here in the US now for 15 years. At the school, I lead a program called the Women and Health Initiative, of which maternal health and reproductive health is the core area of focus. So the issue that we are going to discuss today is pretty much at the very center of our agenda, and a very important one.
That's great, and the work that you've done is really incredible in this area. So I'd love to hear more from you what the research has told us about disrespect and abuse at a global level.
Research on disrespect and abuse is relatively recent. In fact, the maternal health community, global community, didn't focus that much on quality of maternal health care in general until maybe the last 10 or 15 years. And within that larger subject, the experience of care, the experience of disrespectful and abusive treatment was even addressed less often. But now we have some research projects that give us a good sense of how prevalent disrespect and abuse is, and in fact is very, very highly prevalent. In fact, some of the research in sub-Saharan Africa shows that depending on the context, it goes from 15 to 98%. That's what women report as receiving disrespectful and abusive treatment. Research has also identified some drivers of disrespect and abuse, which should be the next target of any efforts that are geared at improving maternal health care. But unfortunately, we haven't done enough research to test different approaches and interventions to address those issues. Why is that? It's a combination of factors. First is that until recently we didn't have like an agreed upon conceptual framework to look at disrespect and abuse. We didn't have common definitions. We didn't have common methodologies to assess the prevalence of disrespect and abuse. And also, to be very honest with you, it's also that we didn't and we still don't have enough funding to do this type of research. So that's, a combination of factors that explains why the body of research in this area is still relatively weak.
And you talked about common frameworks and getting to common definitions. Can you talk about how disrespect and abuse went from being a personal narrative of some women? You know, we've both worked in Latin America, and we know that Latin American women were complaining about this for years, but it was always disregarded. You know, it was always like, well, it's not that big an issue. You know, women are changing. They do need more cesareans. They do need more medical intervention. And it took many years for this to actually become a public health problem. And it took many years for it to start to be defined the way that we talk about it now. Can you talk about that story, that transition of how we go from women complaining to noticing that this complaint is a public health issue? It's not just a personal narrative.
That evolution that you described so well, in part was the result of the efforts of women advocates that started by putting the issue of disrespect and abuse on the map. But as you correctly pointed out, it was mostly considered like an individual issue that sometimes led to legal actions or to changes in legislation that are great. And in Latin America, that's the case of what people refer to as obstetric violence. In other places, it started to become more apparent thanks to the existence of some conceptual frameworks. At the global level, the first conceptual framework that helped us think in a more systematic way about disrespect and abuse was the one that Bowser and Hill developed, that identified 7 categories of disrespect and abuse. That included physical abuse, verbal abuse, stigma and discrimination, retention in facilities, lack of privacy, a number of behaviors or dimensions of disrespect and abuse that women are facing all over the world, but maybe more commonly in low and middle income countries, or at least that's the part of the world our work is done in most cases. So that helped raise the visibility of disrespect and abuse a lot, and also conduct some prevalence studies that showed how incredibly prevalent some of these elements were. So in a systematic review that we did of disrespect and abuse projects in sub-Saharan Africa, we identified that the prevalence went from 15% to 98%, depending on the hospital, depending on the context, depending on some characteristics of the women. For instance, being HIV positive may increase the prevalence of disrespectful and abusive behaviors. Being an adolescent, being an unmarried woman, being a migrant. So conditions that make women particularly vulnerable to disrespect and abuse and to other complications. More recently, I think it was published in 2016, the World Health Organization came up with a new conceptual model for disrespect and abuse that they referred to as mistreatment, that included another layer, another level that went from the individual to the systems level. Mm-hmm. So they included, for instance, being treated with non-evidence-based interventions, mm-hmm. or receiving care that didn't meet the essential standards of care that every woman is entitled to. Being treated by a healthcare provider that doesn't have the right training. Mm-hmm. So, in other words, it took the issue from being only a personal experience, mm-hmm. to being, yes, a personal experience, but also the target of interventions and procedures that are not the best available ones, the safest and most effective ones. Mm-hmm. So the model helped us link the experience of care with the technical quality of care as well.
Okay. And can you tell us more, for example, did you find geographic differences that in certain parts of the world there's more verbal abuse and other parts of the world there's overuse of medicalized procedures? Or what is the research telling us about how this distributes itself around the world?
Well, we don't have enough research to answer that question in a very systematic way, but I would say that definitely over-medicalization, which is a form of abuse, basically the use of unnecessary interventions, is much more common in urban areas, even in low-income countries. That type of care is quite common, and also in the private sector, mm-hmm. Than in the public sector. While other forms of disrespect and abuse might be more common among poorer women and women who are treated in public facilities where the health workforce works under very, very stressful conditions. They are too few healthcare workers. They have to take care of a large number of women with different situations at the same time. They may not have received the right training. In those conditions, verbal abuse and sometimes even physical abuse is probably the most common form of disrespectful and abusive care. In the private sector, you see an interesting mix because women are often treated very well from a strictly interpersonal way. They may be addressed by name. They may be able to bring a companion to the labor room. They may be, well, in general, treated much more kindly, but they are exposed to overtreatment very often because of financial incentives or other incentives that may be affecting the model of care that is provided there.
And what's interesting is sometimes it's the same physicians working in both the private and the public sector, using different forms of disrespect and abuse according to who they treat.
But I think that in general it's more like a systems issue. It's not that much that the women's characteristics prompt or generate mistreatment. It's that the culture and the circumstances in some healthcare facilities make disrespectful and abusive treatment more common and more acceptable. And something that has been normalized, that, well, maybe younger healthcare professionals learn it from more experienced colleagues. When they see how they treat their patients, they tend to do the same and adopt the same attitudes and the same behaviors. So I think that more than trying to change women in some way, although of course we would like all women to be well, healthy and strong and not vulnerable for any reason. We should work at the health systems level and at the societal level to change perception, attitudes and behaviors and make sure that this is considered an unacceptable situation. It's totally unacceptable. So if you want to look at the historical evolution of one dimension of disrespect and abuse, the story of the doulas movement is an interesting one. In fact, it started in Guatemala, and the two researchers behind the idea, the approach, were two doctors from UC Berkeley. Doctors Marshall Klaus and Dr. Kennel. And in fact, they identified that women who came from indigenous communities in Guatemala were treated much more poorly from an interpersonal perspective than women who were white or women who were not poorly indigenous, who spoke Spanish and were like better adjusted, better adapted to the cultural environment in which they delivered. And they evaluated the intervention. In fact, it's one of the few studies that used a rigorous research design to evaluate an intervention aimed at improving the quality of interpersonal care. They did it through a randomized controlled trial, and they showed that the presence of a doula improved a number of outcomes, not only satisfaction, also very concrete process outcomes like length of labor or frequency of cesarean section. So it took maybe 20 years, the doula's idea, to be embraced here in the US. And now, although it's still not very common, it's becoming more widely used. So I think that, well, we need to come up with this type of out-of-the-box, innovative idea. In the case of the doulas, having an advocate for the woman in the delivery room that can help translate the concerns that the woman has, not only in terms of language, but also in terms of understanding each other with the provider, physician or nurse. but also making sure that her needs and desires are respected and taken into consideration. Well, that's a great idea and a great approach to some of the observations that they had made in terms of how the hierarchical system worked in Guatemala. But then they went one step further and they evaluated the approach in terms of very concrete outcomes. So we need that to make our case stronger, to be able to say with all the strength of evidence that this works, this should be done, this is effective and maybe even cost effective, because you are saving money if you have fewer cesarean sections or if labor gets shorter. So I think that we as the public health research community should be doing much more research on interventions and prove their effectiveness, acceptability, feasibility, and cost savings.
So Anna, I want to bring it back down to women now. We've talked about why this is a systems problem, a provider problem. Let's talk about women. How does this impact women? What does this mean to women when they've been abused in childbirth?
Thank you for asking that question. Disrespectful and abusive treatment of women, mistreatment of women, is both a rights issue and a public health issue. The way women are treated means a violation of their most basic human rights that cannot be accepted, cannot be tolerated. It also has huge public health implications, because women, or anyone for that matter, who has been poorly treated in a healthcare facility will not go back there, will not trust the health system anymore. Will, in the case of women, maybe deliver at home instead of going to the hospital, which obviously it's a risky situation. So that disrespect and abuse is a rights issue, but not only a rights issue, has big implications on the health of the mother and the baby. Mm-hmm. And therefore there are two very powerful sets of reasons why we should find a way or different ways to make the quality of personal care of women better in all healthcare systems around the world.
So we've spoken to Jean and Anna about the problems of disrespect and abuse in childbirth in the US and around the world. And now I'd like to talk to both of you at the same time. What do you think are things that we could do, both in the US and in the rest of the globe? What have you seen are the most salient or the most useful things that actually address disrespect and abuse?
I'll let you start.
Sure, thank you. I think there are many things to be done to address disrespect and abuse during maternity care. The solutions won't be easy. There is no magic bullet, because this is a very complex issue and one that is entrenched at different levels from society to individuals. So doing something that is effective and helps women and helps providers and everybody involved in maternity care will require a multi-pronged approach. So we can think of interventions at the health system level. We can also think of interventions at the individual level. We can think of interventions before delivery and in the delivery room. So there are many alternatives in terms of doing things that will help achieving more respectful and dignified care for women all around the world. Of course, interventions would change depending on the weaknesses and strengths of the health system and the cultural environment, but there are some that look promising. One thing before we start talking about interventions, some of the interventions that have been proposed have not been really evaluated, so we are not 100% sure they work. So these are, in many cases, good ideas that, in fact, address many of the issues that we think contribute to disrespectful and undignified care, but they haven't been tested using very rigorous designs and methods.
On the domestic side, quick story. So I was part of a team that was meeting with the Black Maternal Health Caucus a couple months ago. And in that context, they were asking the same kind of question. What can we do to deal with, they were talking the broader issue of maternal mortality, but the biases in care was a subtext for the whole discussion. And the solution that gets proposed all the time is implicit bias training. That we're going to do implicit bias training. There's money now being put forth in congressional bills to provide implicit bias training for providers around the country. And I interrupted them and I said, that's fine, but well, you're a DRPH student. I ran the DRPH program at BU, and we always told students the one thing you cannot propose as a solution is that you're going to do a 1-hour training for physicians and change lifelong experiences to get them to do something different unless you really structurally change the setting that they're in. And so my solution was, I have nothing against implicit bias training per se, but I don't think it's any magic bullet that's going to resolve this issue. What I proposed was midwives, to start training midwives of color. If you want to try to cut down on cultural biases, then diversify the workforce that's providing the care to at least minimize those opportunities. There's no magic bullet, by the way, here. There's no, the assumption had been made in the United States that as the obstetrical workforce became more female, that would resolve all the problems. And our research doesn't suggest that there's that much difference overall between male and female providers in terms of the way women are treated, which we sort of ascribe to the socialization process that physicians go through in their training, is incredibly powerful and leads to a certain perspective on birth that might not value women's personal dignity as much as an outcome, right? We've structured care around we want a healthy baby, and a healthy baby is really all that matters, and everything else is ancillary to that. If you start from that premise, then the potential for mistreatment is that much greater because that person is in between me and that healthy baby. If I perceive that at all, then that becomes my justification for not treating people with the dignity that they deserve.
Anna, what do you think about that? We have, lots of examples of countries in Africa and Latin America where midwives are integrated into the healthcare system, and we're not seeing better results in terms of disrespect and abuse. Is it the provider? Is it the culture in which they're working? Let's try to break it down a little bit.
Sure, that's an excellent question. In fact, as Jean was saying, I think that having female providers doesn't guarantee that women will be treated better. In fact, in multiple studies, it's been documented that midwives and nurses, female in most cases, are the source of the disrespectful treatment. So that's not necessarily the solution. It's a matter of raising the awareness throughout the health system. It's about building teams that know how to handle maternity care in a respectful and dignified way. It's about making sure that someone who can advocate for the woman's rights is there. That could be a family member, that could be a doula, as it's being tried and used in many places around the world. It's also about women empowerment. I mean, women as providers should know that they are entitled to ask questions, to complain when they don't feel that they are treated properly. Of course, there need to be some accountability mechanisms. Maybe it's not going to be possible to do something at the very time the woman is mistreated, but she could do something later, she or her family, and in that way help other women who may go to the same service. So I think it's a combination of approaches that need to be used, some of them targeting the health system and health providers, some of them targeting the women, and some of them targeting the environment, so it's enabling and supportive.
I wanted to go back to something you said about having people in the labor space or in the labor room that are supportive of the woman, for example, a husband, a doula. What have you both found in the research or in the work that you're doing? Does it help to have somebody else there? How does that person help, and how can that person help more effectively?
I think it's a matter of choice, as everything. So obviously, I would only encourage someone else to be in the room if the woman wants such a person. And who that person would be, that's also a matter of choice. But in order for the woman to make a choice, we should offer her alternatives. And as you know, in most maternity services in low and middle income countries, having a relative there, the husband or otherwise, is not even an option. Having a doula is probably not an option either. Not even having a midwife, because, at least in Latin America, the region I come from, obstetric care is highly medicalized, so it's mostly in the hands of medical doctors who may be the less well prepared to deal with some of the emotional dimensions of maternity care, and that they may not be even aware of the issues that we are discussing today. So we need to be context specific to the extent we can, and also mother or person centered. So basically, do or try to do whatever the woman chooses will be the best way to support her during a period she will be very vulnerable.
What have you seen here in the U.S., Jane?
In the U.S. context, the use of doulas has become increasingly popular. Still not huge. We're talking 6, 8, 9% of mothers. But the outcomes can vary considerably when doulas are engaged in the process. We had a measure in listening to mothers of physiological birth. We used a measure developed by the American College of Obstetricians and Gynecologists, and we looked at who was getting a physiological birth. And when we did that, what was really intriguing was it was more likely if the mother had a midwife, it was more likely if the mother had a doula, but the real effect was when a mother had a midwife and a doula. Now, obviously, there's selection bias there. A mother who has both a midwife and a doula is going to be more committed to having a physiologic birth. On the other hand, I think part of what we try to do in systems is to structure the systems to allow people who want to have a particular outcome or a particular process in this case have the opportunity to do that and not restrict them with limitations that don't allow them to have either a midwife because we don't have any in this hospital, or a doula because they might be constrained in that hospital, or they become too expensive to be able to be used.
So you're both also talking about systems levels issues. You know, for example, in low and middle income countries, the fact that you're physically not allowed to bring another person into the space because there's not enough room, because there's lots of beds, because there's lots of chaos in the hospitals. In the US, you might have a situation where insurance doesn't cover a doula, for example. What sort of systems, what would you recommend as systems changes to truly support more respectful care? And I'll also ask you, what things do we know don't work at all? And we keep trying, and they still haven't worked.
Well, one key approach is strengthening the health workforce. And that means many different things. To start with, the health workforce also needs to be respected and treated in a dignified way. And very often we see that that's not the case. Not that anything would justify mistreating women, but still, if you have only one midwife that takes care of 10 or 15 women in labor at the same time without any of the resources that are essential to provide good care, under a lot of stress, under a lot of pressure, that person is much more likely to shout at women or to express their frustration in ways that in fact represent mistreatment and undignified care, but that's probably beyond the control of the person who is doing it at the time. So health care providers should be treated well, should be paid fairly, should be asked to manage a reasonable workload. So that's a very important component. The composition of the team is another one, and we were talking about midwives or female health workers as a potential approach that needs to be studied better. Obviously, the physical environment is also important, conducive to have some privacy, to, very often healthcare managers say that there is no room for a husband or a doula, but that might not be the case if you are creative and innovative and you find a way to make that little space. well, there are many things that can be done at the health system level or the health facility level to make the labor and childbirth experience better for women from an interpersonal point of view, from an experience point of view.
Actually, it's the same situation in the U.S. context, with a slight variation. Obstetricians aren't bad people, right? They want to do well, they want to care for their patients, but they're under not as extreme, but similar kinds of constraints in terms of having so many patients to deal with, being told that you have to get through all of these people in this amount of time. And so when women say, I always felt rushed when I went in on a visit, it's partly because the OB is been told you've got to meet your nut, right? You're going to do 12 visits or 14 visits, 16 visits a day, and they don't feel like they have time to listen to women around these kinds of things. And so I think structurally, systems-wise, if you're going to make a change, you have to change the structure. You have to make it amenable to people treating others with the dignity that they expect. And by the same token, again, to a lesser degree, the treatment of midwives in the United States is often pretty aggressive, and they're uncomfortable in the settings they're working in. And that doesn't justify, but that may contribute to the lack of attention to the individual woman. And then the third, I would say, is that we start valuing women's health for women's health. That the role of the woman is not just to deliver a healthy baby, but that her health is important in and of itself. And her dignity is important in and of itself. And it's not simply a function of doing what she needs to do to deliver a healthy baby to us, and then we don't have to worry about her anymore.
Yeah, I think that's sort of been the underlying premise of all of this of, well, the mom's alive, the baby's alive, what else is there to say? That's what we wanted.
How dare you ask a question about that?
And now you want an amazing experience. Just the baby's out of you, that's enough. How can you've touched a little bit on gender and valuing women as whole individuals who have choices, as you said, Anna. How can we as public health professionals, how can we as a society continue to encourage and push that this is a gendered issue, that we are talking about putting women in a place of value, not just as producers of babies, but also as people who can make decisions and who have preferences and who don't want to be pushed into certain care decisions? What would you say? And very specific to context, because the U.S. is going to be different from other regions in the world.
Yeah, well, it's always more complicated to look at the gender dimension when you are talking about an issue that, because of biological reasons, only belongs to women, like, well, reproduction and childbirth and delivery. But I think that because of gender inequities and gender-based discrimination, women are undervalued in societies and within the health system. And we have seen that much more obviously illustrated when we look at problems that women share with men. Women are treated so much more poorly and much more later than men are for the same conditions. So I think that we need to make a stronger case on why maternal health is still an issue that is heavily affected by gender imbalances. Some people have said that if men were to having babies, maternal mortality or paternal mortality in that case would have been solved a long time ago. So because women are considered disposable to some extent and they don't receive the same kind of attention and resources in their care are not as many as they are for other issues, within a context of competing priorities, of course. So I think that, the gender dimension that you highlighted is an important one to make. It's not going to be easy, as none of this is, but that's something that we public health professionals should make sure that we always convey as one of the most critical messages.
In the U.S. context, we've actually made this into law, right? This bias that we're talking about. And the most obvious example, and really the focus of a lot of attention right now, is around Medicaid coverage of women. And the big movement within the sort of maternal mortality world is the extension of Medicaid. The situation is this: when a woman isn't pregnant, she has to qualify for Medicaid by having an income less than a certain proportion of the poverty level. When she's pregnant, those change profoundly to increase the number of women who can qualify for Medicaid. 60 days after she's given birth, those go back to the original ones. I don't see any better example of engendering that into policy than a statement like that, because it basically says, we only care about you for your ability to deliver a healthy baby. I happen to be on the Massachusetts Maternal Mortality Review Committee, and in reviewing cases, one of the things we have to do is make a determination, was this death preventable? And in looking at that, we often end up fighting over the fact that, yes, this is preventable if we had something like a functional social system that took care of women all the way through, that valued women all the way through. Because case after case after case, we see that the third of women who die between a week and a year after giving birth, they're lost to the system. They're out. That they have difficulty after difficulty. And we'll even see cases where there'll be multiple intersections with the healthcare system that don't capture the problem, don't bring her in, don't work with it. Actually, to be honest, a lot of those interactions are with the legal system as well, depending on the life of that woman. And we've made it into policy. We basically said, unless she gets pregnant again, then we'll continue that disparity. I mean, it's in Texas, it goes from 200%, 205% of the poverty level if you're pregnant to 18% of the poverty level if you're not pregnant. And that's a clear and powerful statement that we value you only in your ability to reproduce.
It also is an understanding of pregnancy as being something that is only affected by what happens to you when you're pregnant and not what's happened to you your whole life and what happened to your mother before you.
Exactly.
It's a very limited vision of what, you know, where pregnancy is. Yeah. So we've talked about health systems, we've talked about provider education. Let's talk a little bit about accountability. You mentioned it, Anna, that women can complain afterwards, or that we have some sort of system that supports women after a disrespectful or abusive childbirth. Can we talk a little bit about what's happening with accountability? Does it exist in some countries? Does it not? Does it work? How does it work? What do you know?
Yeah. Well, we, the Women in Health Initiative here at Harvard-Chan, conducted a study in Tanzania in a very, very large hospital, in their largest public hospital. And we documented disrespect and the prevalence of disrespect and abuse. And we also document the drivers of those cases, or basically what happened to women in those situations. And we came up in discussions with the hospital managers and healthcare providers with some interventions that we tested. So one of them was to establish an accountability mechanism that would allow women and families to complain when they felt that they were mistreated, and then discussed in the context of the OBGYN service, and sometimes even brought up to the management level, without pointing fingers to any particular provider at that point, because I think that's very important. You don't want to make people, healthcare professionals, feel that they are the ones that to blame for whatever happened, because as we were saying before, this is a much more structural issue. That, of course, there are some bad apples, but in most cases, healthcare providers are in that profession because they want to be helpful. Yep. So we try to address it at a much higher level, more neutral level, but still address it very openly. And we even encouraged, and we had a few meetings with the entire staff to discuss some cases, again without naming names, but discussing the issues and making sure that the accountability wasn't only like this box where women would put some, notes complaining about things in, but also a matter that was discussed in the health facility, and some solutions were also considered. So accountability is a key aspect. I think the accountability mechanisms lack in general in low and middle income countries, and they should be one of the main focuses of our actions. in that field.
Okay.
Well, you shouldn't feel so bad. We don't have any in the United States either. Basically, what we've structured is a system where you can do something akin to what Anna was talking about in terms of complaining to your friends, posting something on Facebook, but this inchoate sort of anger that people may have. Or you sue somebody. And it's these two wild extremes of cases that we're talking about. One of the many policies that are being proposed now around maternal mortality is to try to establish an accountability mechanism that's a little bit akin to what they had in England for a long time, which was maternity services liaison committees, not a sexy name, but a powerful tool, because they worked at the district health level and they were a place where care was discussed outside of the hospital, where people could feel like they could bring issues to them in a systematic way. And I think something like that in the United States would be really helpful, to at least have a way to sort through the concerns that people have and have some mechanism out of the hospital, so hospitals wouldn't have to feel as defensive, that would convey that there are problems here. They need to be addressed, and what steps will be taken to address them, short of having to take someone to court and sue them for multi-millions.
So I want to thank you both for coming here today and talking about this issue that's so important for so many people, and I think it's part of our work to elevate this, and that we really are agents of change and trying to make birth more beautiful and more transformative for everybody. So thank you.
Thank you. The childbirth experience stays with women throughout their entire lives. So it's so important that childbearing is not only a matter of delivering a healthy baby and being healthy yourself, but also a matter of being proud and satisfied and, well, convey that to other women, to your daughters later in life, to your sisters. So thank you so much for bringing up the issue of disrespect and abuse that so much threatens the ability women have to have a wonderful experience with childbirth.
Thank you. I would just echo everything Anna said. She summarized the problem eloquently.